Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm also a family doc in Moose Lake, Minnesota at Gateway. I am your host for the program tonight on lower GI problems. And please remember the success of our programs is very dependent on you, the viewer, so please call in your questions tonight. And of course, you can use email at ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Jonathan Gapp, a gastroenterologist with Essentia Health, Dr. Paul Sanford, an internal medicine specialist with St. Luke's Internal Medicine Associates, and Dr. Addie Vittorio, a family medicine specialist at St. Luke's Lester River and Mount Royal Medical Clinics. Our students answering the phones tonight are Reagan Carlson of Sunburg, Minnesota, Alex Higgins of Stewartville, Minnesota, and Sabdi Bravo of Lismore, Minnesota. And now on to tonight's program on lower GI problems. I think I'd like to give you each a chance maybe to introduce yourself. We'll start on the far side. Addie, tell us a little bit about your practice and where you work.
Well, I'm a primary care doctor. I am a family doctor, so I see pediatrics, women's care, and the stages of life all through, the lifespan. I work at St. Luke's Lester River and Mount Royal Medical Clinic, and I've been in practice for 13 years now.
Wow. Paul?
Oh, I'm Paul Sanford. I'm a primary care internal medicine doc. I came here in '91 from Minneapolis, and now I live in the house I grew up in.
Dr. Gapp?
I'm Jonathan Gapp, and I'm a gastroenterologist at Essentia. I've been there for about a year and a half now, since my fellowship. My days mostly look like either a lot of procedures, doing colonoscopies or upper endoscopies, or I'm in the clinic, and I have a special interest in esophagus and reflux as well.
Very good. Except we're on the lower GI this time.
I do all that too.
There you go.
Dr. Vittorio, what is the lower GI? What are we going to put into that?
Well, I mean, lower GI encompasses mainly the large intestine, so disorders that have to do with diarrhea, constipation, some of our autoimmune or inflammatory disorders such as Crohn's or ulcerative colitis, and gas and bloating and all of those things that we love to talk about as doctors.
Is the appendix part of that?
The appendix is part of the colon, so
Well, it's
yes,
right there,
it's part
isn't
of
it?
the, yep.
Right at the end.
Yeah.
Dr. Sanford, tell us a little bit about screening. This is something you're really interested in, and I'd like to get it out there so we don't miss it.
Yeah, no, colon cancer. There's nobody in America that should die of colon cancer. We have ways of detecting it so early that it's cured up with just the biopsy and colonoscopy that Dr. Gapp does. Colonoscopy should start at age 45 and earlier if people have a family history of colon cancer or if they've had previous polyps, or if they have ulcerative colitis, things like that. So it's so important. The colonoscopy is the gold standard. These other tests, not to demean them, they're not as sensitive and specific, and so get your colonoscopy.
Dr. Gapp, as a gastroenterologist, what's the most common problem that you run into in the lower? Let's just stay with the colon.
Well, let's see. I spend most of my time looking for polyps and removing them. So if you call that a problem, that would be one of them that I address on a daily basis for sure. I would say also diarrhea is quite a common complaint that we address in gastroenterology. And just because there's so many different causes for diarrhea, that can include somewhat of a lengthy workup, and colonoscopy and upper endoscopy can be part of that.
What is ulcerative colitis? Paul?
Oh,
Ulcerative colitis.
it's like arthritis of the colon. It's where your immune system is wrestling with your tissue along the bowel, and it'll cause cramping, stools that have mucus, but most importantly, it puts people at extremely high risk of colon cancer. And so people with ulcerative colitis need to be followed really closely by somebody like Dr. Gap. In the old days, we just took out people's large intestine and gave them a colostomy. Nowadays, there are better ways of management and people can live a normal life.
Dr. Gap, if you want to fill that in a little bit, where are we with that disease now?
I would say it depends on the severity of the disease, but for a lot of ulcerative colitis patients, we can treat them with either kind of a pill that they can take, or sometimes they need to take medicated enemas, depending on kind of what section of the colon is being affected by ulcerative colitis. Ulcerative colitis doesn't always involve the whole colon. It can be kind of any part, normally starting at the end, at the anus, and can move proximal from there. So patients who have more of a, let's say I see a patient in the hospital who comes in with ulcerative colitis, oftentimes they'll end up on medications that are a little more heavy hitting, and we call those biologics. And so you might have heard of something like infliximab, which is one that we might use and has been around for a while.
So I have to throw out stool transplant also. And I don't care who, anybody have anything that you want to add on that one?
Yuck.
It's a procedure that has kind of progressively developed and been refined, and mainly as treatment for refractory or recurrent C. difficile colitis, which is an antibiotic, associated and somewhat resistant bacteria that can form in your colon and actually cause life-threatening sepsis, which is systemic infection, or loss of parts of the colon. So we treat it with antibiotics. We treat it with certain antibiotics for a period of time. Things don't get better. They continue to get it. We treat it with big gun antibiotics. Things continue to progress, and people keep getting this recurrent bacteria because our colon is full of bacteria. And so our colon sort of recycles bacteria. It helps us digest food. It helps us use all parts of our food, but there are some that are what we call pathogenic or cause disease, and C. diff is one of those. And so eventually you may be asked to ask your partner, your family, your friends, whether they could give you a sample of their normal bacteria in their stool. It is not ingested orally, it's ingested via a tube. And this is meant to sort of replenish your normal bacteria that can further protect you against infection.
Anything you want to add?
Right now, the only reason that FMT or fecal microbiota transplant is being used is for C. diff. So we're not using it for ulcerative colitis yet. I know that there have been some
There's been some studies on
some
it.
studies on it, and it just doesn't seem like there's at least longevity as far as the effect goes. So as of right now, it's just still for C. diff colitis.
And the choline version for people who don't have, severe life-threatening conditions is taking in probiotics, which our fecal bacteria love to eat and flourish on, and also, or prebiotics, and then probiotics, which are bacteria that are found in our gut normally that we can sort of feed our gut as well.
Dr. Sanford, constipation. It's not gas.
Oh, okay.
Constipation. What can I do if I'm still constipated after taking laxatives?
Oh, well, hopefully the laxatives are the last place you go. The first place you go is eat your fruits and vegetables just like Grandma used to tell you, and try to drink lots of fluids. I tell my folks to take 2 quarts of anything wet a day, whether it's water, iced tea, pop, beer, what to go with your cheeseburger. But that is going to be a healthier gut. Lots of fiber, eat your fruits and veggies, dried apricots, raisins. Laxatives, all they're going to do is, it's like a fire extinguisher. You want to establish a new pattern of eating that'll make your colon happy.
Does smoking affect the GI tract? And in that same line, alcohol?
Of course, both of them. If it weren't for tobacco and alcohol, I'd be selling lutefisk on the corner for a living. Incredible increase in risk of malignancies, alcohol, especially with the liver, which is the upper end of our gastrointestinal system, but tobacco, it can be linked to colon cancer increase as well.
Jonathan, can you explain the process of an endoscopy? Symptoms and whatever why would you do it, and what is the process?
Sure. And I think what they mean by endoscopy is probably, well, we're doing lower GI, so colonoscopy. Is what they mean.
I'm sorry.
Yeah.
Get me down there too.
Yeah. So the process is, the way that it would work is, we'll just go through kind of a patient flow. So let's say you're coming in for your screening colonoscopy. It's your first time, you're 45 years old, you don't have family history, you're staying on top of things. You come in into our kind of pre-procedural area, and our nurses put in an IV for you, and our anesthesia team sees you and make sure that you're safe to receive medications to keep you comfortable during the procedure. Then they bring you back to the endoscopy suite, and that's where we start giving you the medications. And normally you're either fully asleep but breathing on your own, or you're slightly awake, depending on what medications we give you. And then we introduce the scope through the anus, and we go all the way around to what's called the cecum, and that's where you'll find the appendix, and you'll find the small bowel running into it, and that's kind of where we normally stop. Sometimes I'll take a peek into the end of the small bowel as well. Then on the way, we come back and look for polyps and remove those as we find them.
Why can't you keep going?
You can go as far as the scope will let you go. So sometimes we will if someone is been having, let's say, bleeding, and I don't find anything in the colon that's the cause. Sometimes I'll just keep going up as far as I can into the small bowel until I run out of scope.
One of the social determinants of health kind of questions, and I don't care who jumps in on this, where can you get a colonoscopy without insurance, and how much does it cost out of pocket? And then I would add on to that, do you have to have that anesthesia, which is expensive too? So those are...
I from the anesthesia standpoint,
I know some people have done it, that's what I asked.
Yeah, so I mean, you can do, a partial colon, which is a flexible sigmoidoscopy, and sometimes I'll do those on people without them getting anesthesia. And that can be a form of colon cancer screening. Not as good as a colonoscopy because you don't get to see the full colon.
The procedure typically depends on you being relaxed, and most people would not be relaxed with something going into their anus and up through their rectal area. So it's much easier to get a good screening if you are provided the appropriate anesthesia.
Yes, and it is an excellent screen. So
yeah, and as far as payment or coverage or other things, most health plans do cover, including public insurance. I'm not aware of a program that doesn't, that provides them for patients without insurance at this time.
And I have no idea what it would cost. What age can you stop doing colonoscopies?
The answer is it depends.
Yeah.
And so, we start talking about it at age 75, and we might sort of look at someone who has a lot of health burden of other diseases and say, well, you could probably stop at 75. But there are also people with a family history where we continue screening every 5 years. There are persons who've had polyps that we continue screening, and it depends on your quality of life. If you would treat a colon cancer and you're kind of in that in-between period of time, I usually ask patients, if you would treat a colon cancer, do you want to continue your screening to help, determine whether you have risks or not?
So that you've opened up the polyp question. What are polyps and polyp?
Well, think of the polyp as a meaty mushroom along the pipe of your large intestine. And there are multiple different types. The hyperplastic polyps are little barnacles that Dr. Gapp will snip off and you don't have to do anything more. Adenomatous polyps are ones that if you leave them in the intestine, there's a 50-50 chance they'll turn into cancer within 5 to 7 years. Is that approximately correct?
Yeah, normally we say more like 10 to 15, which is why you can go 10 years if you've got a normal colon.
Yeah, and then you have the other more dangerous ones. They're called sessile adenomatous or malignant polyps, where if it's an early colon cancer, you have to decide whether to try to do it with the scope or take a surgery and take out a hunk of the large intestine where the cancer is and then reconnect the two ends of the colon.
And not only does the type of polyp determine, your risk, but also the amount of polyps you have determines risk. And it's gotten, I would bet, much more complex than when I started with regards to the numbers and types of polyps and how often we would repeat screenings.
It is a procedure that has proven its worth.
Oh,
and
yes.
certainly one that,
Yep.
it's just because of where it is, I think that's the biggest problem with it, but it's an excellent, excellent procedure.
Yep.
If a person eliminates junk food, will that eliminate GI problems? So we're looking a little at the upper GI, but our focus is lower, and I'm not sure to what they refer.
I mean, certainly their GI tract gets more healthy with the elimination of refined carbohydrates and other things such as smoked meats and other things. But your gut health depends on a variety of things. It depends on your stress in your life. It depends on who you are genetically. It depends on your diet composition.
John, there's a question. I'm not even sure how to put this one out, but the vagus nerve in my mind is pretty much upper GI. I don't think that's lower GI,
Right,
so
yeah.
we're not with that.
Yep.
And then the next question, how does the psoas muscle affect the bowel? And I don't have an answer.
I don't think it does.
I wouldn't really say that it does. Yeah.
I mean,
No.
obviously there are muscles in the pelvis, which physical therapists are very used to dealing with, that can cause pain or cause discomfort and therefore affect a person's bowel habits, but there's no direct.
Yeah, and if we're going to talk about constipation and we're going to talk about muscles, I mean, I think, and you mentioned the pelvic floor, then we can talk about things like coordination of those muscles. So sometimes if you're taking your laxatives and you're still constipated, sometimes we start to wonder, well, maybe you don't coordinate those muscles in the right way. And then it's actually becomes, then it might not be a medication that you need, but a pelvic floor physical therapist retrain those muscles to coordinate things in the right way, and that can also be a treatment for constipation as well.
And we do see things like childbirth or multiple childbirths affect your, sort of where your organs fall at rest, and different kinks and turns, and whether they, sort of balloon out in certain areas, affecting your ability to excrete waste.
Rectal bleeding. The question kind of starts out with more coffee ground, which I would assume would be more upper GI.
Yep.
But actual rectal bleeding, I don't know, Addie, do you want to take that one
I
on?
mean, lower GI bleeding is typically a red or maroon color. It typically has a blood color to it because it hasn't been through sort of chemical processes from the upper GI. And it needs to be evaluated regardless of how, what age you are. And so things we ask in the office would be, is it painful? Is it non-painful? Can you, feel things there? What is your family history? We can take a look in the primary care office. So we not only look externally, but we use something called an anoscope, which I call the sort of the speculum of the anus. And we're able to sort of go in and look at certain areas in the first 4 inches of the GI tract from below to see if there are hemorrhoids or if you had fissures. And fissures are giant crevasses in sort of the external part of the anus that can be quite painful and bleed.
And the bleeding looks different probably from further up versus right at the anal area.
Yep.
So hospital GI bleed, scoping right away?
It really depends on the rate of the bleed, because the other important thing whenever you're doing a colonoscopy is being able to see. I mean, we can't see through mud, so it's important that oftentimes you be able to take the full bowel prep beforehand, and we can give that quickly if we need to. But in the hospital, if it's a high rate bleed, and that can be from something, if we're talking lower GI, that can be oftentimes from diverticulosis, a diverticular bleed. That's kind of the most common one that we run into. Oftentimes we'll give you the bowel prep is over a couple of hours, and then you'll be going for a colonoscopy quite shortly.
Yeah, and I think in discussing, diverticulitis and diverticulosis, it's important for patients to know that if you have an episode and you're treated either by your primary doctor or through the ER, it's important you follow up with your gastroenterologist in the following months after that, because we do see that some colon cancers or colon polyps can lead to diverticulitis episodes.
Paul, what are diverticuli?
They're caves. When along the pipe of the large intestine, you have these little croppings of tissue, of a hole. It's like a little dead end piece of bowel, and they just happen more in our culture because we eat refined processed foods. In Vietnam, the Philippines, it's non-existent. Well, it's rarely existent, but anyway, diverticuli often don't cause any problems. But if they get infected because of impacted stool or microscopic trauma from a fish bone, it can cause life-threatening sepsis.
So are there dietary restrictions if you have diverticuli?
No, eat all the gravel and fruits and vegetables you want. The rougher, the better. I don't know. Do you disagree with that?
No, I agree.
Moving things through quickly is the key.
I think people we're told for a long time to avoid nuts and things with seeds, but then you're missing out on a lot of great healthy snacks, in the end, it didn't seem to matter if you ate those things. So keep eating those healthy snacks.
We're better.
Nuts, peanuts, and bit foods. We spent many years doing that.
Yeah. Popcorn, don't eat popcorn.
Popcorn.
Yeah. That's okay.
It's okay. Just eating foods as close to the way Mother Nature made them as possible is always good for all of your body.
So we left people hang a little bit. What causes C. diff?
Well, it's a
So one of you guys.
overgrowth of opportunistic bacteria, Clostridium difficile. If you've been giving people antibiotics to treat their pneumonia or whatever infection, if it kills off the happy part of our microbiome, the bacteria that help us to live, then Clostridium difficile will take over. And it is a bully. It will just knock around your intestine. It can cause something called megacolon. It can be fatal. And unfortunately, there are not a lot of antibiotic options besides vancomycin and rarely metronidazole. But yeah, it's a booger.
And we've seen more and more of it, and that would be why your doctor, sees you for your cold, and at 5 to 7 days says, "Well, I think this will pass, and we don't have to use, antibiotics to treat this. This does not look bacterial." And that's why we're constantly, every day, as primary doctors, making that decision is to lower your risk of side effects from antibiotics.
Yeah, fewer antibiotics, the better.
What are the treatments for hemorrhoids? We'll just move it down to that end.
Don't grunt. Yeah. No, just preventing constipation. Don't strain. I don't know.
First the fiber. Fiber, I think a lot of is underestimated. I think you get people on a good fiber supplement if they can't get it all through diet. Most people are not getting their 25 to 30 grams of fiber that they're supposed to be getting every day. And so if you start on a supplement, I think that for a lot of people, their hemorrhoids will improve. Some people, they're too large, they're too severe, and then you're talking about hemorrhoid banding, which can sometimes be done by a gastroenterologist or by a colorectal surgeon. If they're very severe, then there's hemorrhoidectomy is kind of the next and last final step. But that's a pretty involved procedure in an operating room, and so we try to do what we can before we reach that point.
Can diverticulitis lead to cancer?
No.
Indirectly, yes. Probably directly, no. I mean, anything that causes inflammation for years
That's
and
true.
years
That's
can
true.
cause, and the GI tract is chronically sort of overturning its cells. That's the purpose of it, is to make more cells to continue to operate. But directly, no.
But it is important after an episode of diverticulitis to get that follow-up colonoscopy done if you haven't had one done 2 years previously to that, because sometimes it can herald, like you were saying earlier, a colon cancer or the beginning of one.
Just a little step aside, celiac disease, and maybe sprue. A couple comments.
Large intestine.
It's small intestine.
It's small intestine.
Yeah. I'm not
we're
familiar with any
stepping
large
aside.
intestine.
We still, even though we have a population that could have more prevalence of that, we still think it's a fairly rare thing. And by and far, there's probably more people with a perceived gluten intolerance than a actual true gluten allergy. So we have good tests to sort of determine that, but you do have to be eating sort of the foods to do screening. We do see people with sprue. We all have several patients in our practice with celiac sprue, which is true, gluten allergy, and then they have bloody stools, or they lose weight, or they have iron deficiency associated with these things. So it's not a disease that is subtle, I would say, but it is something we look for when we can't figure out what's going on.
Paul, a 30-second closure
Ooh.
on bowel health.
Oh, a happy bowel.
We've talked quite a bit around things, but just a summary of what you would do in the office or say.
I just say what I've been saying this evening. Listen to Grandma. Eat your fruits and vegetables, 5 different colors of fruits and vegetables a day. Eat your whole grains, peanuts, dried apricots, raisins. That's going to be the best way to have a happy bowel. Avoid processed foods. Try not to have too many cheeseburgers every day.
Keeping stools soft,
Yeah.
fluids, fiber.
Yep.
I want to thank our panelists tonight, Dr. Jonathan Gapp, Dr. Paul Sanford, and Dr. Addie Vittorio, and our medical students, Reagan Carlson, Alex Higgins, and Sabdi Bravo. Please join me again next week for a program on neurologic problems, headaches, stroke, MS, and Alzheimer's disease, when my panelists will be Dr. Vikram Jadhav, Dr. Chris Thiessen, and Dr. John Wood. Thank you so much for watching, and have a great night. Thank you, panel.
Thank you.
Good job.